Hi.
That number that you gave me, it's ringing, but nobody's picking up.
Okay. So let's wait. Yusuf? Did we get in touch with Luis directly?
No, I sent him an email though.
Okay. Hi, Nicholas. Good to see you.
Hi, everybody. Hi, Salman. Hi, pleasure as usual. Let's see what will happen here. I'd suggest maybe wait for another 5 minutes and see if we get a contact. Maybe something unexpected happened to Professor Pimenta, and that's the reason why, because he definitely confirmed that he will be with us today.
Okay. We have another couple of minutes to go, so let's see.
Yeah, I tried to text this number, but probably it's a landline. It says Sao Paulo when I try to phone it, so it's definitely close to Luis, but I'm not getting him.
Okay, maybe in the meantime, you can tell us something about World Spinal Column Society and why we are doing this and all that.
Okay, so yeah, so this is the first and I'm sure not the last of series of webinars and case discussions that we are starting under the hat of the World Spinal Column Society. We are planning to do that initially every fortnight for a couple of times, and then we go to monthly events. The idea is that we meet with the big names in spinal surgery, and we give them chance to discuss cases and give chance to our members to discuss the cases with them, to see what are they doing at the minute, what they can present with interesting topics and present interesting cases. And like that, we learn from them, and we also have the chance to talk to them in an informal fashion. I believe this will be of interest for our members, and this will be something that will have the members will have interest in this. We can also allow the members to ask questions, to discuss different topics that they're interested. And we are preparing this as well in a short while. So this is in short what we are trying to do. Imat is just texting me another number, so I'm gonna try that once again. And Salman, you maybe can tell us more of what we are planning as part of the activities that we will organize for our members.
I think World Spine has been there for the last 20 years, as you know. There are many things that we have been doing over the years. Our main thing regarding World Spinal Column Society is interactive cadaver workshops and interactive courses. And we are doing a lot of them over the years. Unfortunately, because of COVID, we haven't been able to do that. We recently successfully did this a huge virtual World Spine. I think the main salient features of virtual World Spine were that we had 16,000 participants on day one, and we had 14,000 plus participants on day two in this virtual World Spine. And there were people connected from all over the world. And there was huge participation from China, from India, from Pakistan, from Indonesia, from Malaysia, from all over Europe, from South America. There was a huge participation. I'm sorry, I'm not sharing any slides at the moment because we are just waiting for Luis Pimenta to join us. From this, this was the first time that we have had an interactive quiz in which 600 people registered, and we finally picked 10 people who went into a second round and did that. From that, we got top 3 people in the world winning that quiz from different countries. Then we had poster presentations, and we had abstract submission as well. And all that actually was great for young neurosurgeons. And that's what we plan to do. The idea behind doing this Meet the Expert is to be able to chat with the expert, and you can ask questions directly and come up with your own discussion with them. And on top of it, they can decide how you want to have your career panned out and how you'd like it to happen in future. Paulo Pereira is here, who is from Portugal, has been with us for some time. He's a brilliant spine surgeon. He's a very nice MIS surgeon. We really admire him for that. I think we will start with, since Paulo, we don't see Luis here yet, we'll start with Paulo and we will interview him. So you all can ask questions to Paulo regarding his career, his future. So we start by, Paulo, why did you decide to do spine surgery in the first place?
Well, it's a mix, like a lot of things in our life. I think it's a combination of maybe some luck, some things that just happen at those times. It was not a primary decision, let's say. So I was a resident in my neurosurgical department in the third year, and at those time our department didn't do a lot of spine surgery. It was mainly a brain surgery department. And then someone was to be chosen to start with the waiting list of the spine patients at the time, and for some reason I was proposed to do that, and then it's like picking cherries. So it was from one thing to another. So I got more interested on spine. I started doing some spine operations that were not done at the moment in my department. So I went abroad and did some fellowships, and one thing brings the other, and that's how it happened.
Okay, and why MIS? Why minimally invasive? What benefit do you see in minimally invasive? And many people who are old-fashioned surgeons say, it doesn't do any good, and there are a lot of side effects and a lot of problems with it. How do you see that?
Well, part of the reason why I started with MIS, apart from being logical to me, so if you can provoke less collateral damage, that should be a good thing. But on the other thing, I was young at that time, so I've been young some time ago, and
still young, Paul, still young.
And so like many young people usually get attracted for new things and new technologies. And for instance, this is the topic of this webinar, during like a lateral fusion in a prone position. I see it as an attractive thing for particularly for young people. So when you are young, you want to do something different, because otherwise you'll be just one more in your department doing the same things that all the other people are doing. So I think all of these new techniques and and less invasive techniques, more endoscopically, more percutaneous, typically attract more people who are just finishing the residency or starting doing the spine fellowship. So it's I think in my view and what I've seen in last decades is that typically this is the target for new techniques. Young surgeons who want to do things differently. I understand that we all of us know the Scott's parabola, where we see new techniques coming up and down, and so sometimes it's difficult to know from the beginning what is gonna stand and what is just be there for some time, but I think we never know the answer.
So what would you suggest for young neurosurgeons or young orthopods who want to be spine surgeons? How should they start their career? Where should they start from? And what should they learn first? Should they go abroad, do some fellowship somewhere, or should they continue to work and try to come up with new stuff?
I think it's a combination of both things. Also, it depends on where you are practicing. Of course, the more developed is the department where you work, probably the less need you feel to travel abroad. And if you are practicing in a department with a lot of limitations, probably you need more to look for other opportunities. But this is also something that is being totally new in these times that we are living now. Is that all of these webinars and the web-based platforms that we have now to discuss, to put our cases to discuss with another group. We see a lot of Zoom and presentations on Zoom and on YouTube and other platforms. We can really learn a lot, not leaving our city and our department. So I think this is an outstanding opportunity that we are living on these days, and no matter where we are in the most recondite place in the world, since you have internet access, you can have access to a lot of learning that is different from books. One from the cost, because most of this is free, and on the other side, because it's in real time. So when you read a book, you read something that has been written some years ago, and on the other side, if you see when you listen to these presentations and you have the opportunity to interact with spine surgeon and another colleagues, you can really see and save how the trends are, where the trends are going, and which train you want to jump in.
Okay, and what about learning curve? You know, there's this problem with talk about learning curve that you, for example, for a lateral approach, you take about 30 to 50 cases depending on what you're used to or not. And for example, transfemoral approaches, up to 70 cases for some people, and maybe the minimum is about 30 cases. So, yeah. You know, how do you go over this learning curve when nobody else is using this technique in your center?
Yeah, this is a key issue, because we have done a research in my department that was quite interesting some years ago, because the second scenario that you're talking about was my scenario. So I started doing minimal invasive techniques in my department where no one else was doing that. So I learned like it happens in quite often. I start learning that from my cases and from something clues that I got from other surgeons that I visited at that time. But the majority of the learning was made by myself with my patients. And I think we have new different opportunities that are coming up on these days. One is simulation. Simulation is there, and probably it will replace at least partly some cadaver training and other kind of training in the upcoming years. Even in societies big societies such as Eurospine, we are introducing more and more simulation. We are starting doing that in our courses, because this is a very nice thing, because it's not a patient, so you cannot harm him, and then it's very reproducible, because you can train as many times as you want. So you can train to do a suture of a dura through a tube or whatever, for instance, and you can do, if you don't succeed, you can do that as many times as you want. But apart from that, I think that having a mentor is something that is very, very important. And so if you can learn seeing someone doing the procedure, and then, if possible, starting your first cases with that person on your side helping you, I think this is a very good thing and a big advantage. Like I was saying before, we did that, and we tried to compare my learning curve with minimal invasive TLIF of the following residents from my department who started doing that. And at that time, of course, they started doing that, having me by their side, and their learning curve was much faster, much quicker than myself. So I think this is a good thing.
Brilliant. I think, Paulo, I'm grateful. Thank you. I think it seems Luis Pimenta has got busy in some emergency or something. We can't contact him. So everybody, if you want to ask questions to Paulo, you can write in chat or raise your hands, and we take questions later on. But I think in the meantime, I'd ask Nicole Pieve to present on lateral approaches. So we do a presentation.
Okay. And, sorry, Salman.
Go on. Yeah. Off you go.
Okay, so thank you so much, Salman. Pleasure as usual, as always. And I would like to, before I start, I would like to just do a comment what Paulo said. It is admirable that Paulo did that when he started on his own. It's always difficult to start a new procedure that nobody is doing it in your department. Because if something goes wrong, you don't have anybody to help you, and you need to have even more courage to do that. But when we listen to Paulo, obviously there is people that are happy to do that, even though they don't have backup. They are still happy to advance, and this is why the neurosurgery is advancing, because we are happy to do things that nobody did before, and that and even if we don't have backup, but still we have to play safe. We have to, as Paulo said, we have to do enough training, not on patients. Before we start something new, we have to be very sure, and we have to be confident that we will do the right thing. Initially simple cases, and then with training it comes more difficult cases. Right. So I will share with you a few slides. it is I'm gonna talk about the lateral approaches and what is the main benefit on lateral approaches. This is something that was not prepared for this occasion, but I think this is something that is in line with the current topic. So I will start sharing with you now. Let me share my screen. Okay.
Imad, can you share your screen? Yeah, that's fine. Thank you.
Do you see my screen now?
Yes.
Okay, so I'm going to talk to you about indirect decompression. Indirect decompression is something that is the mainstay of the lateral approaches. This is one of the most advantages, the biggest advantages that we have with the lateral approaches. We can do indirect decompression of the nerves. Before I start, I just wanted to show you, this is a slide that I have that you've probably seen in my presentations before. This is how the minimal invasive techniques were, and in general, the surgical techniques were developing over time. You can see that interbody fusions are with us only for the last 60, 70 years. And minimal invasive techniques are with us only for the last 20, maybe 25, 30 years. But now we
sorry,
have...
Nikolai, can you please, Nikolai, sorry,
yes.
Could you please share this, the slide share? So just go on to, just go on to full screen at the bottom.
Oh,
bottom,
yes, okay,
bottom.
yeah, sorry. Yeah.
On the right, yeah, that's,
yeah.
Thank
okay.
you.
Yes. Yeah. So as you can see, this is how the different surgical techniques were developing in time. And as I said, only last 20 years, 25 years, we have minimal invasive techniques with us. But now, as you can see, we have minimal invasive techniques for nearly everything, and we can choose. And the lateral approaches that we are talking about today is one of the minimal invasive approaches that we use, and we achieve a lot with these approaches, provided that we have the right indications and the right patients, of course, as usual and as always. So just to remind you, this is a good, I always, when I talk about minimal invasive surgery, I like this definition of minimal invasive surgery that was given by McAfee back in 2010. So minimal invasive surgery is a surgery that will give you less damage of the collateral tissues. It will give you less morbidity, and your patients will recover faster. But you will still reach your intended surgical goals. And this is the beauty of that surgery. You damage less and you achieve the same. And we achieve that with direct decompression, indirect decompression, muscle sparing, interbody fusion. And we do all that with different approaches. So what is the indirect decompression? That is a decompression of the spinal nerves without resecting the compressing tissue. And we can see indirect decompression via two main points. Number one is segmental procedures, which is distraction between two vertebrae. And that will give you opening of the neural foramen, and increasing the epidural space. And this can be done by all these interbody fusion options that we have nowadays: A-LIF, O-LIF, L-LIF, or X-LIF, T-LIF, P-LIF. All this is interbody fusion, and all that is relying more or less on indirect decompression as well, with some of the options direct decompression. We also achieve global alignment with the spine and the spinal cord. We allow the spinal cord to migrate away from the areas of compression. In case, for example, with the lateral approaches, we achieve correction of kyphosis, that is what we are achieving, global alignment of the spinal cord and the spinal canal. So this is a slide that is demonstrating to you the indirect decompression. You can see that how this disc has collapsed, and as a result of this, you have bulging of the annulus, and that is causing anterior compression. And you have also buckling of the yellow ligament from posteriorly, that is providing posterior compression. By inserting interbody spacer with whatever approach you have on mind or doing, you achieve unbuckling of the yellow ligament, and also you achieve anterior decompression by unbuckling of the annulus. This is the indirect decompression, and this is how it works. This is the main principle. So let's speak now a little bit more about the segmental procedures. This is destruction between two vertebrae and restoring the disc height. That is what we have demonstrated with the diagram just now. How we do that? We do that with disc space utilization. We use different interbody spacers, and like that we are recruiting more space by achieving unbuckling of the ligaments, and we creating more up-down space in the foramen. I'm gonna just show you a few examples. This is a case that I have done not long ago. This was one of the first cases which I have done with this procedure. This is a good example of a minimal invasive procedure. As you can see, we have managed to address two levels which were completely collapsed, and the patient was having problems with that. Following this procedure, we managed to get with following this procedure, the patient had a significant reduction of radicular pain and also of the back pain, because these were the two levels which were creating problems. We confirmed these two levels before. As you can see, this is quite degenerative back, but we managed to isolate two levels which were creating problems. I managed to isolate that with injections. Most of my multi-level degeneration cases are going through facet and nerve root injections before I finally decide where exactly to go. And like that, I'm trying to localize one or two levels which are most affected and they create problems, and I go with these two levels. And most of my patients are having significant improvement. I always tell, so this patient obviously will not be, I'm not aiming to send this patient to his 20s. As you can see, this patient is born in 1943. But what I'm aiming with these procedures is I'm aiming to make things bearable for this patient, and with proper approach and with localizing the procedure to single or two levels, I'm usually possible to achieve that. As you can see here, I have achieved this procedure, and this surgery was done only with this small incision, which is lateral incision. You can still see the skin clips which are still there when the patient is doing the erect standing X-ray, which is now a standard post-operative investigation for me as well. The other thing that I managed to achieve with this patient is I have avoided putting posterior screws. You can see that the patient has no posterolateral instrumentation, and this was another thing that was good with that procedure. I can use these lateral approaches not only for, this is a good demonstration of the technique that we use to do the lateral approaches. This is the demonstration of XLIF approach, which is the transpsoas approach. There is approaches which the modified of the lateral approaches is the olive approach, which gives you access to the vertebral, to the intervertebral disc anterior to psoas, and like that you're guarding the neural structures which are around, and also you have better access to the disc. I will show you another case which I have done at some point in the past. For me, the lateral approaches are now not only used as a primary procedure, but sometimes they are used also following another surgery that I have done. I can see this patient had TLIF surgery at level L4, L5, and unfortunately on a later stage developed adjacent segment degeneration. This is a good indication for me to do a lateral approach for this patient, and that's what I have done. You can see I have removed the screws from 4-5 because I have good fusion there, and I have inserted the screw. I have inserted a lateral cage at level L4, L5. You can see here that I'll show you before the surgery. Before the surgery, you see the how narrow is the foramen. This patient was complaining of not only back pain but radicular leg pain, and you can see following the procedure how big is the lateral foramen. So this technique is really potent to give you foraminal decompression without needing to go posteriorly or and resecting bone or ligaments. So this is the post-operative result that I had. So these are the two cases that I have found today. Just as a immediately after I was asked to do that, I would ask now maybe Paolo to comment on what I have presented, and maybe Salmana as well. What are your comments on this?
Nicola, if you could unshare your screen, please, first.
Yeah.
Great, thank you for sharing these cases, Nikolai. And so just let me ask you something. Do you have a preference regarding lateral approaches of going pre-psoas comparing to going trans-psoas? Is there a preference, or it depends on the patient?
So when I started initially with my lateral approaches, I started with trans-psoas approach. But lately I'm moving to anterior to psoas approach because the advantages that the anterior to psoas approach is giving me. For example, with trans-psoas approach, I cannot access L5S1, while with the olive approach, I can go there. It is better for me to do olive because it's more convenient for me to work. The way how the surgeon stands with lateral approach is different if you do trans-psoas or if you do the anterior to psoas. It is more ergonomic for me to do that. Another advantage for me was that I was always worried about the exiting nerve root when I was doing L4, L5, because L4, L5 level has quite significant percentage of exiting nerve root damage because the nerve root is very close to your working field. With the anterior to psoas, I normally don't have this problem. The way how I do it is I try to have direct visualization. Like that, I'm possible to see any structure that I manipulate, and I'm possible to push the psoas with all the important structures posteriorly, and I'm possible to move the peritoneum, and I have nice corridor that I can work and do different things. So lately anterior to psoas, but I started with transpsoas.
Yeah.
What is your experience with that?
Yeah, it's basically the same. That's why I found interesting when I first saw the lecture that we should have today from Luis Pimenta, and I would be very interested to listen to his experience, because my trajectory was exactly as yours. So I learned to do transpsoas, and then I always did that under monitoring. Sometimes I had some problems with L4-5 to get rid of the iliac crest, to get rid of the lumbar plexus. And then when the press psoas or the olive technique came out, I thought it was really an advantage, and I completely changed it to going anterior to psoas. That at the end, the surgery itself, it's basically the same. So even the position of the cage is about the same. Just the entry point in the skin and then in the spine is different. One of them, for me, one of the disadvantages of these techniques is that since they are done in the lateral position, I know that some surgeons are doing the lateral fixation as you do, just with the lateral plate, or just with the cage that is integrated with screws that can be inserted through the cage. But I tend to replace my patients in a prone position after the lateral approaches, because at least in my hands, that helps me to increase the lordosis, the segmental lordosis. So I found it interesting when I saw this pupil like Luis Pimenta and Juan Uribe, for instance. We've also talking quite often about doing the lateral approaches through the psoas in a prone position. So theoretically, should have a better lordosis there.
Yes.
But yeah, I've never tried to do that. So.
Me neither, and I was also interested to see this, but hopefully we'll have a chance to see it still, maybe in one of the other sessions that we are organizing in the nearest future. But let me ask you another question.
Sorry, Nikolai. Before you ask, there are a couple of questions on the thing. Parvat Kumar has asked: do you have some kind of video to show, because they couldn't understand completely what you meant by pre-psoas and post-psoas?
Okay.
And
I don't have video, but I have a slide that I can show and that I can explain.
Sure. And then there's a question from Harshad Parekh, which is the concept of inserting spacers in space and leading to decompression without exiting of taking out the disc and ligaments. Can you please explain how it results in decompression, and why lateral and why not posterior?
Okay, I can share my slides again and I can explain that. Shall I?
Sure.
Okay.
Yes, please.
Right, I'm doing this now. Right. So let's start with first explaining how the procedure works. I think this is good anatomy that can
full screen. Yeah, thanks.
Can give us the understanding of how we do these things. So you can see here on that side of the slide, you can see this is the olive trajectory. Olive stands oblique lateral oblique lateral interbody fusion, and then L-lift stands for lateral lumbar interbody fusion. So, or this is so-called X-lift approach, but because X-lift is industry name. That's why many people now are using L-Lif. So L-Lif and X-Lif is basically one and the same thing, but because X-Lif is industry name, we prefer not to use industry names, and we use L-Lif. So as you can see here with the lateral approach, you go through the psoas muscle and you split the psoas muscle. This is a good picture that can give you understanding as well. So I will start with the layers. You remember, I will explain to you the technology, how, sorry, I don't know. Okay. So I shared with you this, no, it was just before that. Please excuse me. Yeah, so you can see this is patient that was placed in direct lateral position. This is very important for your approach and for your surgery. So you have to place the patient in directly in strictly lateral. So when you do strictly vertical X-ray, you see only single lines. You see here that you see single pedicle. You see facets are single. So that gives you information whether your patient is strictly lateral. And then this is the skin cut that I have done. This is probably about maybe 3-4 centimeters skin cut, and this is the first layer that you cut. And this is where I use knife. This is where I use scalpel in the whole surgery. Nowhere else. So after that, I will show you the layers that I cut. So after you cut the skin, then you have, of course, the subcuticular fat. You go through that bluntly, and then you have the 3 muscular layers of the obliques and transverse muscles, which you also open in a blunt fashion without cutting anything. Maybe sometimes I cut the fascia with the scissors, but that's it. And then you go into the retroperitoneal space, and then with your finger, literally you slide down inside the abdominal wall until you start palpating here, until you start palpating the psoas muscle. And then you can just stop. You can put your instrument, which usually is a key wire, to get your disc, and then you do your dilatation. So I'm describing now the X-Lif procedure. So after you feel your psoas muscle, you put a key wire, and once you're sure that you're on the right disc, you start sliding over that key wire dilators, and these dilators will split the psoas muscle. So that's why it's transpsoas. You go through that psoas, and like that you achieve corridor. This is the corridor here, which you are you're having good access to the disc, and you can do discectomy. You can put a pretty chunky cage, and you can do correction of kyphosis and many other or lateral bends as well. And this is how you do the surgery. The difference between the direct lateral approach or X-Lif and the Olive procedure is that once you put your finger on the psoas, you don't stop there and you don't put your key wire, but you continue then sliding forward your finger until you reach the anterior edge of the psoas and until you feel the disc space. Usually you do that. Usually you do that I usually do that on that side. But if need be, depends on the curve, I can do on the right side as well. So this is the difference between the two approaches. One is splitting the psoas muscle. The other one is going in front of the psoas, and then you can dissect the psoas and mobilize it backwards. and you have very nice corridor, and you can do disc, you can do discectomy and cage insertion, you can do corpectomies, you can do many things. This is, I believe, the answer of one of the questions. Now, with regards of the other question, I will show you this case. So you see that we have previous TLIF, we have adjacent segment degeneration, and you can see here that is the neural foramen. And see how the neural foramen is collapsed. It's tight. There is no space for the exiting nerve root to come out. This is because on one hand, you have this collapse, you have this disc bulge here, as you can see, and it's pushing from front. And then you have also buckling of the yellow ligament from back. This is what is stenosing the spaces. So when you introduce the big chunky case, you see what is happening. All of a sudden, you have nicely opened intervertebral foramen. This is the principle of the indirect decompression. You don't need to go and remove the tissues. By putting a big cage, you stretch that ligament and that annulus that was buckled anteriorly, and by stretching it, that creates more space. And same thing is happening with the buckled yellow ligament, which was buckled inwards because of the telescoping of the two facets. But now, when we have stretched the two facets with that large cage, we have created a lot of space. This is the principle of the indirect decompression.
Nikolai, I'm sorry, just a question. How do you decide what size cage? Because generally, and to what extent, lateral extent it should cover in order to give good decompression and to make sure it doesn't cause problems again of adjacent segment disease in future? So
in order to, that's another big topic of that's a good long presentation. This is so in order to decide what is the cage, how high should be the cage, do you need lordotic cage, what will be the angle of the lordosis that you need to achieve, you have to calculate your angles. You know, for example, that pelvic incidence minus lumbar lordosis has to be less than 10 degrees. So this is the pivoting point, and you have to there is nowadays there is software. You can just put the numbers, and the software will calculate for you. The software will give you.
Which software?
There is different softwares. Obviously, we are not talking about industry things here because of advertising issues. But every company now is that is offering you to work with them can give you access to different software which will calculate the angles for you.
Sorry, Paolo, you were asking something. I apologize.
No, just saying that that probably I can just show you like one or two cases illustrating the decompression that you can get with the lateral approach, and then the lordosis that you can get.
Nikolai, can you unshare, please?
Yeah, sure.
Unshare. And Nikolai, can you answer the question written in front of you on group chat? You can see that. You can, it's, so the question is, which is better, OLE for LF?
Which is better, OLE for, this is a question that is difficult to answer. The best procedure for you as a surgeon is the procedure that works best for you and that gives you less complications. Strictly speaking, if you would like to start doing these lateral approaches, I would advise you to start with the XLIF approach because that will give you good understanding about the anatomy. And
Paolo, it's at the bottom. Paolo, it's at the bottom in the middle.
Then after you do a few cases, you can progress to the
right
approaches.
Okay.
Sorry.
Okay.
So I think probably start with XLIF and then continue with OLIF when you do a certain number of cases and you feel comfortable, confident.
Okay, so I think just a comment, just to show a short video of an OLIF, just to try to illustrate what Nikolai has just said. So so again, OLIF, you do your skin incisions a little bit. So this is the projection. What you see in these lines on the left part of the in the left picture is the posterior and the anterior projection in the lateral lateral decubitus of the disc spaces. So you can just go anterior, your incision is anterior to that, and then you are working in an oblique direction, as you can see on the right side. And then you also, as Nikolai said, so we have the 3 layers of the muscle. So put your finger there, enter the retroperitoneal space, palpate the quadratus lumborum, and then the psoas muscle, and then you go anterior to that if you want to go OLIF, and you go anterior to the psoas directly to the disc space. And just so this is an issue to orientation. So this is typically, it also improves your ergonomic because you stand upright, so you stay anterior to the patient all the time, and your X-ray, if you are not using navigation, if you are using just a C-arm, you can have your C-arm in place during the most part of your surgery, because since your approach is a little bit more anterior to that, you don't have to put your C-arm back and front. So just common, this is important as well to check. So this is the video, and I will try to show it quickly here. So this is the patient in the right lateral decubitus. So the marking of the discs. So the entry point anterior to the discs in the abdomen, it can be vertical or oblique or transverse. So what I do, since I use autograft, I use the same incision to collect bone from the iliac crest, as you can see here. And then I close the fascia, the external oblique fascia over the iliac crest, and then open it again when I'm, so we see this is the fascia of the external oblique. So these are the fibers of the external oblique here that we just dissect and don't cut. Then we have the internal oblique here, perpendicular to those fibers. We also open them in the direction of the fibers, and then the transverse muscles and the transverse fascia. So this external oblique here, again, internal oblique downwards, and then the transverse muscle is open already, and the fascia transversally, and this is the retroperitoneal fat. So you enter the retroperitoneal fat here. So you dissect it together with the peritoneum until you see the psoas muscle there. So this is going to be the psoas muscle, the genitofemoral nerve that in the surface of the psoas muscle, and this is, and just let me go a little bit back here. So this is going to be the anterior surface here. So this is the anterior, sorry, back again. So that was the anterior surface of the psoas muscle, and then you go anterior to that and put your first needle there. You want to be in the anterior part of the disc, and then you use your dilators. Again, you are in an oblique approach to the disc. Those are the sequential dilators. This is the working set of tubes. Again, you are always anterior to the psoas muscle, and then you fix the tube to the disc. So this is the anterior edge of the muscle, and this is the annulus, the lateral part, anterolateral part of the annulus fibrosus of the disc. So you incise the disc, and then this is just a standard discectomy as if it was an A-leaf or any kind of ACDF. So you just go to the contralateral, open the contralateral annulus so that you can increase the dilation. You can see it there. So you open the annulus, and then, as Nikolai just said, we use the cages that that we want to introduce. And these are really big cages, much bigger than we can use on a T-leaf, and that's why we can achieve a very good and direct decompression and restoration of lordosis. So I will just gonna stop here and just show some postoperative images. I'm just gonna show another presentation that has some postoperative cases. Just let me see where I have this.
Although there is a question about how do you deal with the big red structures there?
The big red ones. I always stay posterior to that. So this is a very important question, because we have to check that we are that in the preoperative images, either CT scan or MRI, you must see if you have enough space to go if you have enough space to go anterior to the psoas, in between the great vessels, particularly the left iliac vein. If you have enough space between the left iliac vein and the psoas to go in. I'm having some problems here to share my screen. Just let me see if I can.
Paulo, I have noticed you were not securing your retractor to the vertebrae. Is that correct?
No, I do that. I secure them. I use a screw. I use a screw and secure. I just use one screw, so I just secure it either to the upper or the lower vertebra to allow to open the retractor if I need it.
I'm always worried. So the way how I do it, I secure up and down. I secure for the upper and lower vertebra, and I don't secure the retractor to the stand, to the table. My reasoning behind that is because when I start hammering, sometimes you have quite enthusiastic hammering to thread the cage inside the disc, and I'm always worried that the body of the patient, whatever good fixation you use, is moving differently from the table. And when the table is moving differently, obviously, if the retractor is moved to is attached to the table, it moves with the table, not with the body. And if I'm close to the big red structures, as it was said, I'm worried that this might damage them. What do you think about that? Am I paranoid, or there is some reason behind
I don't know. All of us have some things that we do because we believe it, or because it happens sometimes, or because we are feared. We are afraid that it can happen. But to be honest, I never thought about that. So I secure the retractor to the table and to one of the vertebrae, just the upper or the lower vertebra. So I like to have all of it fixed.
It's
There is
because
that.
you have it's because you have all the thin patients in Portugal, and you've got all these people eating potatoes in Ireland.
Well, it
But
was
my
you
patients
could
are
see
not
the
very
video. You could see the video that the patient is not that thin.
thin. Yeah.
But
Okay, let's
again,
do
just,
this. Let's do
yeah,
this case.
just show the postoperative the images basically. So this was a lady with a low back pain and neurogenic claudication. I will just go quickly on this, but as you can see here, those patients have this kind of 3-level stenosis here with a disc herniation at that level, also a disc collapse here, but basically a stenosis, particularly on those levels, with also with a spondylolisthesis there, and you see the tortuosity of the nerve roots, and so you can see the spondylo there, the spondylolisthesis there, and you see that also this worsening on flexion as it's typical. Sagittal balance was okay, and we did the 3-level lateral approaches. And what I wanted to show you is 2 things. One is this indirect decompression that Nikolai was talking about. So we did no direct decompression here, just putting the cages. And as Nikolai said before, you see the buckling of the yellow ligaments that completely disappear on the postoperative image comparing to the preoperative images. So you don't have tortuosity of the nerve root. So this is the decompression of the spinal canal, and we did nothing posteriorly. The only thing we did posteriorly was putting the screw and the screws, and the other thing, as you can see here, comparing prior to postoperative, we could achieve a better lordosis there and a good alignment. And the alignment is particularly important when you get the cage as anterior as you can see here at the level of L3-4. That's the level, and 2-3. That's the levels where we achieved. We could put our cages more anteriorly. That is the segments where we got more lordosis. So this is basically what I wanted to show here, just as an illustration of the indirect decompression and of the not only of the foramina but also of the spinal canal that we can achieve for distracting the yellow ligaments.
I think brilliant. This case was excellent. I really enjoyed that. Both talks.
Very demonstrative case indeed. Very demonstrative case.
Thank you.
Excellent. Shall we have a look at multiple choice questions that we shared?
Okay, so do we have questions there?
Yeah, it will be coming up.
Okay.
So first thing is obviously the questions. Okay. Who wants to take this?
Right, okay, I will start. What is the significance of teardrop source or Mickey Mouse sign when planning lateral lumbar interbody fusion surgery? So we have 32 responses. Most of the responses are indication to use X-ray. 37% indication not to do L-lift surgery. That is the correct answer. The reason behind that is because when you have this so-called teardrop psoas or Mickey Mouse sign, this is when you see the psoas muscle quite big and the anterior margin of the psoas muscle going beyond the anterior margin of the vertebrae, and it's going to be very difficult to access, and you don't have space there. That's what Paulo was telling you. You have to see your MRI scan before you start planning.
Okay, next.
Yeah.
Okay, the specific anatomy of which of the following exiting nerve roots is most endangered when performing the lateral lumbar interbody surgery. So 39% are answering L4. And this is the right answer. Again, there was a good slide shown by Paulo. It's just, I think it was just flickered in his presentation, but it were possible to see that L4, unlike the other nerves, is quite anteriorly. And that is why if you do transverse approach, that is on your way when you're splitting the psoas muscle, and you can easily endanger. That's why if you do lateral approach, you can do it without neuromonitoring at level L3-4, L2-3, for example. But if you do L4, L5, neuromonitoring is recommended. That's because of L4 being quite anterior and easily endangered and damaged. Okay, what is not an indication for lumbar interbody surgery? So we have 42% acute disc herniation. That is the right answer. All the rest, collapsed disc, lordosis restoration, deformity correction is indication for lumbar interbody fusion. But if you have just acute disc herniation, you can do and just do discectomy. And then finally, what is describing at best the mechanism of neural decompression when performing L-lift surgery? Good 52% of the participants answered with indirect decompression, and this is the right answer. We have explained in the indirect decompression, and seems like the majority of the participants understand it now, which is good.
Brilliant. And can you please show Imad regarding the membership for World Spinal Column Society? And Nikolai, can you explain to people what all this is about?
Yes. So basically, what we are trying to do with these webinars is we would like to have you again. We would like to make it interesting for you, and we would like to keep you participating. That is why if you register for our webinars, you will have a period of free membership for our society that will give you different perks. Like, for example, you will be possible to participate. You will be possible to get certification. You'll be possible to talk to the presenters, to ask your questions, and you will be possible to develop your knowledge. For those that are very active, and we keep track on that, you will have a chance maybe in one of the future webinars to become coordinator or moderator to co-moderator to one of these webinars. So this will be good for you as well.
Also, the perks also include access to the MIS book that is on the website.
And there are other books also coming.
Yeah. So thank you. That's brilliant. So when is our next webinar? In a fortnight?
Yes, in a fortnight. We initially will keep the webinars in a fortnight, and then probably we will go once monthly based on the preference of our participants. So shortly we will announce the next topic of the next webinar.
Hello, your comments?
Well, thank you for joining. This is, well, quite different from what we expected. We were hoping to listen to Professor Luis Pimenta's presentation on a related topic that for sure he had some kind of emergency that could not make it. But at least I hope that we could foster some discussion here, and again, if you have some suggestions also for topics, for speakers that you would like to see here, please send us an email, and we look forward to meet you in our meetings, either virtually or face to face when our reality allows it.
Brilliant. Nikolay, do you want to wrap it up? Do you want to have a group photograph? Everybody switch on their video, please.
Yeah, I will just say thanks for participating, and we were very happy to have you, and hope we will have you in the future. This is the first of the series of webinars which we are preparing, and they will be interesting and even more interesting next time. So just be with us and smile now for the photo.
No, can we all switch on our videos? Can we all switch on our videos so that we can take a group photographs, please, everybody? And then you can smile as well.
Everybody should say webinar.
Switch on your videos, please. Everyone. Okay, smile. And thank you. And thank you, Paolo and Nikolay and Yusuf. You've been very kind helping in the background. Yusuf, would you like to comment before we close? Yusuf.
Yusuf is muted. Let's unmute him. Ask to unmute. Okay.
Okay.
Thank you for giving me the chance to speak. Well, I think it was a great lecture, and approaches to the lateral spine. And for people who have not routinely seen them, and we often postulate that these are very difficult approaches. But having seen the surgical steps in detail and going through the presentation, I think it's pretty much doable. All we need is a bit of guidance from these webinars and some experience in terms of training with you guys, and hopefully I think these will be the thing of the future.
Okay, thank you, everybody. I think we will have a session in a fortnight. Nikolay and Paolo, since you're the moderator, you can close the session, please.
Okay. So, yeah. Paolo, please go ahead.
No, there is a colleague asking to talk, Dr. Abdallah Zaidan. Is that can we unmute him?
Okay.
I don't know.
Yes, thank you very much, Professor Sharif, Professor Paolo, and Professor Nikolay. I'm really enjoying your series, and I'm really proud to be part of your meetings all the time. Professor Sharif is always didactic, and really he deserves to be our first things. Congratulations for being our the president of our society. I mean, that's much gain for us. The only thing that I want to note is what Dr. Yusuf said. That was very, very, very interesting session. Yes, we didn't attend the main presenter who was supposed to come, but we got really good benefit from it. What I suggest is, if it is possible to make some sort of cadaveric dissections or presentations of how to put the material online also, like what I have seen in, I think the Seattle Foundation, the Seattle Spine Foundation is doing that now, and I've attended some of their meetings. But when we have good, excellent experiences like Professor Pereira and Professor Peeve and Professor Sharif, I think this is very, very nice for this minimal invasive techniques. I'm a spine surgeon since more than 25 years. I'm used all the time to do the big openings. I mean, it's not that much difficult for me to go to the psoas, but there are small tricks which I got benefit and learned today from Professor Pereira and Professor Peeve, which really I'm going to applicate on my patients. So maybe if we can do these cadaveric dissections, Professor Sharif, I think maybe you can have the occasions there. That will be very, very, very fine and excellent. Thank you very much.
I think, thank you, Abdullah. It's brilliant what you said. We are working on it, and we have the webinar, all the recordings of the webinar that we have had up till now. They're all available on LNS Neurosurgery YouTube site. Besides that, they are all interconnected with WFNS Spine Committee, with World Spinal Column Society's website as well. Yes, we are going towards anatomy cadaver sessions as well, and I think we will have them. We have recordings of all the cadaver sessions that we do and we have been doing in the past, so we can use them. On top of it, we can use surgical videos as well and showing the anatomy at the same time, and to make it easier for people who are learning or people who want to move from open surgery to MI surgery. So I think we can do that. Definitely, we'll keep your suggestions in mind. Okay, thank you, everybody.
Okay.
Can we wrap up, Paulo, please?
Okay, so thank you again for joining, and I hope this has been useful for you in spite of the drawback that we have and we missed Professor Pimenta's lecture, but still I think we have a good time discussing some topics related to lateral approaches, and we look forward to seeing you in future initiatives of the World Spinal Column Society. Thank you.